and I hope everything will be fine.
Yeah,
Thank you
sure.
for joining
Thank you
us.
so much.
Okay. Do I should start and show you presentation, or you have any question for the beginning, or how we want to start?
Oh, it's not. It's perfect, doctor. You can start with your presentation.
Okay. Welcome everyone, guys. I hope that I will explain and maybe make some refreshing for a couple person, because I saw a couple names and I know a couple person from the group. I thought what I can show you actually, and what will be the best things for show actually priorities, challenges, and also mistakes for all of the information. And today I made some kind of overview, and I thought a lot about high quality in basic and also high quality in advanced technique during any emergencies. And actually, when I thought about it, I try to find couple priorities, and I hope it will be fine with good knowledge, and I show you couple very, very important things. But actually, before we will start, I want to show you that the whole adventure with patients and the whole process.
What are you doing?
Good evening. I want to show you that before we will start with the whole adventures with treatment of the patient, um, it's really important, actually important for people. And if we decide that we have chosen to treat patients, we always should remember about big empathy, and always we should listen in our patient. That if you will have any time some kind of big challenge in your life, please watch Patch Adams movie. For me, this is one of the best movie what I saw in my life, and I saw a couple times. And every time when I have some even like problem with my work, I usually back to this movie to watch again and to catch the big motivation to help someone, to help people, to spend time with patient, and also to work good with my students. That's my one of the always task when I have any problem, any challenge. I'm thinking about it. Okay. If we thinking about any beginning, that always I hope that you will remember initial five. You can remember give me five actually, and give me five that will be like safety, what happened, kinematics, how many victims, additional resources, and we should thinking about any help. This is some kind of proposal if we are pre-hospital, but actually if we will be in a hospital, but we will also couple the same things. First, our safe, and always safety at the beginning. Then actually what happened, and we want to know what kind of problem have our patient and how we can treat him, but we will need like more things to make the best treatment. Kinematics, but not only like what actually happened in mechanism of injury, but also like what kind of health problems this patient present. How many victims? This is usually before like pre-hospital. But if we are in a hospital, we can also have some chance to see couple patient in the same time, for example, in ER. And then we should thinking like about the priorities. Who first? Additional resources. It's like any expert consults, any labs, any scans, anything what we want to be sure what happened and how we can create the good treatment in any cases. If we're thinking about the first priority, the safety first, it's usually the whole scene. and like pre-hospital, but also like in a hospital, safety issues, scene situations, maybe the beginning of triage if we have mass casualty incident and we have a lot of patients, and we should thinking about who first, like I told you before. Every time when we studying PPE is very important, and right now actually during COVID-19, not only personal healthcare professionals start to use in every cases, because like many times I saw doctors, nurses, paramedics without gloves, for example, and we usually we should use every time gloves if we're thinking about some trauma, always eye protections, mask, gowns, but also actually the same equipment during COVID. We were working in the same equipment every time. Same situation. This is actually the most important question. So what happened? Every time when you will introduce yourself, when you will see first time your patient, and you will try to figure out some kind of initial impression, like first 15 seconds, how he looks, what is his condition, how he's breathing, maybe some kind of couple information about the triangle, actually how he looks like. The second things, what we can tell about the patient breathing and how looks skin. This is actually three first if we want to recognize some couple things, like for example, this patient looks more like a sick person, maybe the second one looks more like a healthy guy. And then if we actually know what happened or we don't know, we should organize couple very important question to build the knowledge. What kind of problem we have? What do we want to do? How we want to start? Priority number 2, every time after scene safety, is usually control bleeding first. Every time when you will see any massive hemorrhage, any bleedings, decision is always the same: stop the bleedings. Because if we will not stop, the volume will be lower, the volume of bloods and the volume of fluids inside our body, and then we will have some shock. Then we can have also cardiac arrest. We will have more work. Every time when we will see bleeding, this is always on the top. This is the one of the big priority in every case. Even guys, if we will see that someone has a cardiac arrest on the beginning, and we are really sure that there is cardiac arrest, but we also see that someone bleeding, we should stop the bleeding. This is always on the top. Okay, any question for these 2 priorities? Because weather was fine today. That's my dog. His name is Simba, like lion, small lion Simba from Lion King. Any question for this time?
I have a question.
Yeah.
So when you inquire, let's say, a patient who is bleeding, like what is the best way to bandage that, like that bleeding? Like what's the best way to like apply the tourniquet?
Yeah, this is a very good question. On the beginning, we should thinking about like from which area we see the bleeding, and then if there is like from extremities, it's good to make some pressure of the big arteries. We can thinking about brachial, or we can thinking about femoral artery, and we can actually press, and then that will be the beginning, and we can check how looks the wound, how big is it, and what kind of dressing we will need. But if the bleeding is really massive from extremity, we can thinking about the tourniquets. to stop so soon as possible. The big deal, it will be when we will press the artery and then we will apply the tourniquets above the bleeding, but usually in the area where we have only one bone. Then it will be since the beginning we will close the massive hemorrhage and we will stop it. If the bleeding will be from some area when, like for example, from groin or from some crotch or from underpit, and we cannot use a tourniquet, we can thinking about good gauze, and we're thinking about the packing wound. But also, it's really useful right now, hemostatic agents, and we can also thinking about that kind of dressings. Okay.
Thank you.
Yeah, welcome. Some kind of couple information or the idea about the stop the bleeding. Maybe we will in the future make some another class or some another meeting, and then I will explain or I will focus only of that kind of problems, because like I showed you, this is the big priority always on the top, and it's good to know how to use. But actually, the best idea it will be when we will create some workshop, and we will spend even like 1 hour with some dressing, with some hemostatic agents, with some gauze, with some tourniquets, and I will explain how to improvise, how to use a certified tourniquet to stop the bleeding. We can thinking about it, guys. Okay, priority number 3. Actually, I spoke with Nikita a couple times, and we create the title of this presentation, but we discuss about actually basic levels and advanced levels. And every time when we're thinking about basic, it's like some kind of qualified first aid or first aid. And this is a question like, what we should know, how we should work if we will see something in emergencies. It's really good, for example, in cardiac arrest, if someone will start before paramedics arrive for the scene, resuscitation. Is good if someone will stop the bleedings. Is good if someone will keep the airway open. Is good if someone will thinking about aspirin, but will ask about the anaphylaxis allergies before we'll give aspirin during heart attack, for example. But also like basic levels is usually basic life support. And I hope that you will always remember these rules about good, high quality resuscitation. Today we can, and I will give you ask the question on one of the last slides about what it means perfect CPR. But if we know that the basic CPR but high quality, it's 30 to 2, 100 to 120 beats per minute. 30 to 2, it means 30 chest compression and 2 breaths. But during COVID, or if we don't know, like before a victim, we should focus only on hands-only CPR. 5 to 6 centimeters depth. Every time we should thinking about proper chest recoil. This is actually high quality. But how we can provide the high quality all the time? We should switch every 2 minutes person who compress. We should thinking about minimize of any interruption without just compression. This is actually high quality, and this no flow time, what it means time without perfusion or time without circulation, is very important. Or CCF, that's chest compression fraction, time with circulation. during when we compressing should be so high as is possible. Every time if we're thinking about a basic, we should thinking about AED. I like jokes that's not DEA, but actually we can ask like, why not? DEA, it's Drugs Enforcement Agency, but also in Spain, DEA, it's mean defibrillator, external automated, that you can also like make DEA hard, and that will be information about defibrillation. It's good to know where is the closest in our near the defibrillator, like in every dormitory in our university, like in every big buildings in our university. It's good to know if we're working somewhere that it's available and it's working and a battery is full. Maybe this is not our rules, but if we can check sometimes, it will be okay. Don't worry about it. Right now, it's very popular automated chest compression devices or mechanical chest compression devices. Pre-hospital and also in hospital. We can thinking about in hospital cardiac arrest or out of hospital cardiac arrest. The challenge for a team of paramedics is one, because they are usually only 2 person in the ambulance, and it's not so possible actually to create very or perfect CPR. We can thinking about perfect CPR because it's like a lot of things to do. It's a lot of task, but we have only 4 hands. And if we will focus on the chest compression manual and we're thinking about airway management, the question is who will administer drugs? Who will make something more? Who will thinking about H's and T's? Who will do another extra points to treat patient if we will find something? And if it's only possible to attach the equipment device who will start high quality compressions, it will be very, very good. Priority number 4, advance. If I'm thinking about advance, I'm always at the beginning thinking about the ABCDE approach. There is like a lot of problems. If we want to recognize everything, if we want to stabilize everything, if we want to find a cause, if we want to create the best care, it's good to use some kind of structure step by step. Then we will not miss anything. And this is actually like the first step. It's always airway maneuvers. Every time if we're thinking about assessment, we should be sure that airway are open. I hope that for more of you, it's only like the meeting with me is some time of refreshing, but if you can remember, like OPA, oral pharyngeal airway tube, it's 2 methods to check the proper size, bone to bone or soft tissue to soft tissue. And then we will use some kind of periscope move and put the tube inside the airway. NPA, nasal pharyngeal airway tube, it's some silicone tube for the nose. Usually we starting from the right hole, and we should check the size of the small finger from the patient and size of the tube, and we should compare. Supraglottic airway devices, LMA, LTD, like laryngeal mask, laryngeal tube device, or IGEL. IGEL is actually one of the type of LMA. Advanced method, endotracheal intubation tube. Please remember that during resuscitation, during many emergencies, intubation is not a golden standard because we have some easier method. They are faster. They have the same quality. When we will recognize the problem and we will stabilize the patient, then we will thinking about intubation. For intubation, usually we should have good experience. If we not have, it can be a problem for us. This is one reason actually why right now, since 2019, intubation is not a golden standard. For example, during some couple emergency cases or during resuscitation. Like airway first. Breathing and ventilation. Always we should know patients breathing or not. If yes, how fast? That's mean respiratory rate. How looks like saturation or oxygenation? Please remember if the respiratory rate will be too slow or too fast and it will be not adequate, we should thinking about mechanical ventilation. If saturation or oxygenation of the tissue is too low, it's mean less than 94 or less than 90 in acute MI, then we should thinking about start supply oxygen. Every time if we doing something around our patient, we should auscultate. Auscultation will give us answer, for example, about tension pneumothorax, or it will be some kind of beginning of preload. Examination if something is bad, and we should palpate our patient. And also very important, if we using some advanced technique of airway management, then we should thinking about endotracheal end-tidal volume of carbon dioxide level. If we're thinking about the non-invasive measurement of partial pressure of the carbon dioxide, that's normal, like physiological is 30-50. Sometimes you can find 35 or 55 millimercuries. But if there will be like less than 10, it's mean that our chest compression during resuscitation is not adequate. If we will have more than 10 during resuscitation, it will be good, but this is not enough. We want more. More, it's mean more than 15. If suddenly carbon dioxide will start increasing, then we should suspect ROSC in the next analysis, but it's not mean that we should stop right now chest compression for analysis. No, if we just start and we just seeing during the new cycle that the end-tidal carbon dioxide increasing, then we should thinking, okay, continue, but think about that we can suspect return of spontaneous circulation. Circulation during assessment, heart rate, central and distal, that's mean pulse, skin color, and also CRT, it's mean capillary refilling time. We should squeeze tissue and check the time. Usually it should be less than 2 seconds, sometimes less than 3, but like more than 2, it's not normal. Heart auscultation, and also we should thinking about 3 leads and then about 12 leads of ECG. Disability and differential diagnosis, the next next area during assessment. Here we have 2 methods how we can recognize the mental status. We can use AVPU scale or we can use Glasgow Coma scale. Please remember always about sugar. And actually here, if we're thinking about mistakes, one of the big mistake in many emergencies, it's that we forgetting about the sugar level. We should know how looks like the glucose area. We should calculate. If you will see millimoles, that you can remember times 18, and then we will have like milligram of deciliter. That's mean milligram of percent, and then maybe for someone will be easier. Today, actually, if there will be like less than 70, this is some kind of part of alarm. But if there will be like lower, we should thinking about the glucose administration. The next area, it's pupils. And also this is one of the common mistake, often because also like healthcare professionals, they forgetting about checking pupils. And then neurological examination. The next area is exposure. Exposed to, actually, we were thinking about head-to-toe examination. We should thinking about some kind of part like trauma assessment to be sure that every part of the body is okay. During assessment and also after assessment, we should thinking about prevent hypothermia. And if it's only possible, always, I told you about empathy, that's respect patient modesty here, to be professional, to be sure that we just create good work. Okay, perfect CPR or perfect advanced life support. If someone has class with me, I hope a couple person have class with me before. You know my goals. That's, you know what is a goal very often during my class about resuscitation process. And it's always good to know the algorithm. And we have actually like two ideas, two pathways. The first is timeline of shockable rhythm, ventricle fibrillation, always shock. Even that will be like fine VF, that means small ventricle fibrillation. We also should thinking about shock. Please remember, small dog is always a dog, or small horse is always a horse. That means the same, small VF is always VF. If we see ventricular tachycardia with wide QRS complexes, we know that we should always check pulse to confirm that this is pulseless or without, pulseless or with pulse. But one of the mistake very often, it's like when someone just recognize cardiac arrest, tap and shout, call for help, start chest compression, and in meantime, someone join, grab the pads or paddles, make quick look, and decide, okay, we have ventricular tachycardia. It's not needed to check one more time pulse if just 10 seconds before we start chest compression, because we recognize cardiac arrest. And this is also like very often one of the mistake, because we remember ventricular tachycardia, always check a pulse. But I just confirmed 10 seconds ago, there is VTAC, that it's not needed to confirm again. If we have shockable rhythms and we can, when we turn on equipment, we can shock first time 200 joules less than 30 seconds since the beginning of turning on equipment, it's really good. And then after shock, we should focus of equal 2 minutes chest compression. Today, one of the new idea, it's a person who will use a defibrillator before analysis should inform aloud 15 seconds for next analysis. That here you can see like the next or second analysis, it will be 2:30. That means 2:15. It should be information aloud 15 seconds to next analysis, preparing for shock, 360 joules, and press and charge. Then during this 15 seconds, when we continue chest compression, and suddenly we will tell, okay, stop analysis, we have equipment just already to give the next shock. And I used here 10 seconds for analysis. That's mean 240, second shock, 360. And we're using, I showed you here American Heart Association guidelines, AHA. That's if we will use AHA after second shock, we will give first milligram of epi. Then after third shock, we will give 300 milligram of amiodarone. And then after fourth shock, it will be epi again, because epi is every 3 to 5 minutes. And after fifth shock, it will be amiodarone 150. We will continue so long as is possible. Epi during shockable rhythms, so long as we will actually stop because patient died or we have a risk what is more optimistic. But amiodarone, it will be only twice, 300, and second dose 150. On the right side, you have also in a table the lidocaine if there is not available amiodarone. But it's like amiodarone is popular right now that if you will not have, you can check how administer lidocaine and how often. Timeline of, sorry, I not change here. Timeline of PA or asystole. If it was the same story and patient collapsed or stopped and we seen cardiac arrest and we just started and we have some equipment available to make the quick look first. And during quick look, we analyze and recognize that this is unshockable, no shock rhythm. Then if it's only IV or IOX present, we should start with epinephrine and we just initiate first cycle of resuscitation. Then after equal to minutes, it will be next analysis. 2:30 here and 4:30, I gave plus 10 seconds to analysis and 2 minutes of next cycle. That during those third cycle, it will be epi again, then cycle without epi, and then cycle with epinephrine again. If it's only possible, perfect CPR again. We made everything correct. We focus on the high qualities, and we have some time to start looking for any H's and T's is good. A question is always how long, how many minutes we will spend. It's not so easy by PEA. Maybe it's easier by asystole, but it always depends what is the age, what happened, what was the condition of the patient before. If we know about something and we can create the final decision earlier, maybe it will be not so difficult. But usually it is difficult. Priority number 5, H's and T's. Please always remember about it. Hypoxia, hypovolemia, hypothermia, metabolism problems like hypoglycemia, hyperkalemia, that's mean hydrogen acidosis very often, but also toxins, tension pneumothorax, both thrombosis, coronary and pulmonary, cardiac tamponade, and trauma. Every time if something happened, and even it will be shockable or unshockable rhythms, we should thinking about recognizing, about looking for priorities of the H's and T's. If we will find a cause and it will be possible to stop the cause, that probably will give more chance to survive. If not, probably final answer will be that patient will die. And this is usually also big problem, and sometimes mistake if someone will not use a structure of the H's and T's. It's always good to know. It's one of the priority. It's always good to start thinking about it. When it's not so easy to give good answer because very often first we should organize, we should build a team, we should start with good dynamics, and suddenly if everything will be stabilized and we will provide perfect CPR, then we will add H's and T's. Component of the assessment. Here is also like a couple things what we should thinking. I showed you in couple areas, like when I told about ABCDE approach. But actually, if we're thinking about all of the components, we should have good knowledge about the vital signs, about the condition. We should thinking about sample interview, sample history. We should thinking about neurological examination. That's mean AVP or Glasgow Coma Scale, motor and sensory reaction and pupillary response. And also, like, we should thinking about evaluate each region. We should make observation, auscultation, and palpitation if we want to be sure that everything is fine in head-to-toe exam. Priority number 6. It's good when we build the knowledge about patient condition. If we will know about the previous problem, if we will know about maybe reasons why a patient is here. It's good to know about allergies, but actually also it's very important to listen patient about his social area, about some social problems, because maybe that will be some couple answer why he has a problem with health and he's here. Symptoms, you see chest pain, difficult with breathing, weakness, dizziness, headache, maybe some symptoms like strokes before, and problem with muscles of the face, everything, every symptoms. Allergies, we should ask not only about do you have any allergies. This is mistake. We should ask about the allergies for medication. It's good to ask about some specific substances. It's good to ask about food or for some insect venom. Very often people not thinking about it. But if someone has had some kind of anaphylaxia after contact with some specific medication or substance or something, usually people will give us answers so fast as is possible. And please remember, doctor, I have allergy. Okay, but for what? And we should give some couple questions. The same about medication. It is not only to ask like, what kind of medication are you taking? Do you taking anything, or when you took the last time? But for what kind of, how much, or how many? When was the last dose? Do you taking regular or irregular? Good knowledge about medication, it's very important. Very often older patient, and usually very often male patient, they will give you some kind of piece of paper, and that will be all of the information because doctor put on the card and then gave patient, and patient keeping that all the time. Past medical history. Disease, what kind of? Stay in a hospital, when was the last time and why? And also any surgical operations, what, when, why, what happened? It will be always couple questions. This is not only like, yeah, I have hypertension. Yeah, but what, how, when, how high, do you taking meds? That's always good to know more and more and more. Last meal or lunch, what was it? Any specific, and actually when? This is also like part when we can talk about some specific substances, about fluids, about alcohol, about narcotics. Usually patients they drinking like always 2 beers, but it's good to ask like how many beer it was. And events, usually what was happened before, about even preceding injury or about events problems, what happened. This is also like very important. And actually, that's some kind of couple couple priorities of the medical side, but we also should thinking about the communication process for to build good team dynamics, to work proper, to listen, to be decisive, to be assertive, and also to create the best proposal of treatment. We should know about situation. It's good when we will know something about the background. We should create good assessment, and then we'll thinking about recommendation. This is also some kind of part if we will want to like give our patient for someone to another department, or if we will join for and then we want to ask like how was the situation, what was first, you find an assessment, and what do you recommend it, or what you've done, what you made with this gentleman or this lady. And now, guys, couple things about mistake. Usually the mistakes, when we thinking about it, the one big, in my opinion, in every emergencies, it will be when we will not use a proper structure of the assessment. If we will jump from some area to another area, then I will back. Or if we're thinking that in the team we will want to make, we will want to give, if I will be team leader, or maybe that kind of example, if I will be team leader and I want to delegate someone for some task, and I want to order something, it's good when I will order only one task for one person. It's not can be like, okay, Peter Janusz, could you start IV line, check glucose, and also start with blood pressure and oxygenation? It's actually too much. It's too many tasks. It's better if we will tell Peter, could you attach the blood pressure cuff, tell me what is the level of BP? Then when Peter will inform me, it will be good if we will give another task. If I will thinking about step by step, if we will create any chaos or it will be some panic, then it will be only worse. I discussed yesterday with my grip in Sim Center about result during resuscitation, and actually about our afraid. What are we afraid during resuscitation? That patient will not survive? It's true, but what do we want to do for his survivor? We should create the best treatment what we can. We can make the best perfect CPR, but patient will not survive. And that will be not our mistake. That will be our problem in our mind, but it will be not our mistake. We will improve that we made everything, and we should feel good with that, and we should discuss about it because we made everything. But the main problem it will be when we will forget about structure of the protocol. It will be mistake if we will focus on the advanced levels and not about the basic. it's very often that we're thinking about intubation and then we're not thinking about chest compression. It's very often that we're thinking about fluids, resuscitation, but we not stop the bleeding. It's very often that we're thinking about drugs, intubation, advanced assessment, but the quality of ventilation and chest compression are not enough. It's very often that we forgetting about end-tidal volume of CO2. But this is very good information about some continuing criteria for resuscitation. And we can thinking that, for example, if during first 10 minutes, we will see that the carbon dioxide is more than 15, probably in next couple minutes, we can suspect return of spontaneous circulation, ROSC, and also very often neurological outcome. But if we will not see that the end-tidal volume will increase during first 10 minutes, that we will not suspect any positive result. That what I can yeah, I have problem with word. What I can wish you guys, yeah, that you will thinking about structure and about algorithms, and you will keep that all of the things around, and you will work about good communication. Like in my opinion, structure, algorithms, this is some also like part of the structure area, but also non-technical skills, communication, good tone voice, be decisive, ask whole grip, all members of the team, think out loud. Oh, this is good, because maybe if we will share our knowledge, or someone from my team will share a knowledge, that we will find the idea of the treatment. That's for me challenges, that's for me mistakes, but also that's for me the priorities. Any question? You sleeping or not?
No, doctor, we're listening.
Okay.
We're listening. There's a lot of information at once. It's all very useful too, so we're trying to take it in, you know.
Guys, show me your faces. I will be satisfied, because like if I'm spending during by these teams a couple hours sometime, and I see only like PJ, ST, GD, MP, that's not enough. Like, good. George, thank you. Yeah. Now Danusha, now Dalia. Yeah, thank you. Stefan. We have Paulina. Hello, Paulina.
Cześć, doktor.
Cześć, Paulina. And Peter Janusz. Peter, we always will thinking that you are Peter or Janusz, and we will not find.
It's both. It's both.
We will not find the proper answer. but now I have smile on my face. Peter, all of our dummies, the male dummies in Sim Center, since couple of weeks are Janusza.
Wow, what a pleasure to hear.
Yeah, and every time when students will start making some assessment, it's like, Mr. Janusz, how you feel today, or Miss Jadwiga.
I feel honored.
Yeah, that sometimes is like Miss Bożena. Guys, any question? I hope that yeah, I catch your expectation. I know that probably you've been interested that I will show like couple cases and something, But actually, I thought about it, and cases are okay, but priorities are better. Question or comments?
I have a question, doctor. So you work in the front lines in the hospitals, yeah? So catching up the lives and saving it at the first time. So it's pretty clear and obvious, like not every single time you get to save them. So how do you come up with it on your everyday life? It's not like you do it for a week and then go along. It's your everyday for the rest of your life. So you see a lot of death, losses, impairments. How do you come across mentally about this?
Yeah, it's good to think good, and it's good to discuss about any hard cases. Like students who's been in sim center know the rules about debriefing. And every time if something will be wrong, something will be hard, we will feel some pressure after. We saw a death, we saw something strange, that is good to discuss with someone. It's good to think out loud. It's good to go for the coffee, for the restaurant, for cafeteria. It's good to lock in our, in the physician room, and it's good to spend with nurses and ask how you feel. What was that kind of experience for you? Because for me, it was hard. If there will be any problems and you will see that you feel some stress after, it's even good to not drink beer or vodka. This is not good. It's good to like go for the gym, yes, but it's good to discuss with the best friend. Or if that pathway will be not enough, maybe we will need even psychotherapist. But actually, so long, I told you about it, like so long is when we will be satisfied about after worked what we made. I made everything what I could. And I'm honest for myself. I'm happy with that. I made everything what I could, but the result was wrong, was not good. It's easier to explain. It will be, me to one, it will be really difficult if suddenly you will understand that we not made everything what we could. And silent is not good. Silent and quiet in the room is not perfect. Sometimes we will need, but very often it's good to discuss. It's good to ask. It's good to tell something, someone. Usually we holding or we keeping everything inside our mind, but it's good to share with someone about your observation, about your explanation. Like for me, I'm thinking about it. I saw many deaths, guys, and I saw children, I saw small kids. I will live with that for the rest of my life, but I feel okay. And one important thing at the end, maybe about like the answer for your question. Please be honest and also empathy, with good empathy for family members. To listen them, to find good place for explanation what happened, to find good words, but not medical. People, the family member of our patient will be on different levels. And yeah, different levels is maybe not good word, but actually like, you know what you know what it means. Like sometimes that we made everything. Well, yeah, I just back properly. Okay, any question?
Hi, I have a question. What would be some quick advice that you would give to any students that would like to go into emergency medicine, and we're still in our first, second?
Yeah, could you, Alejandra, could you repeat please the last couple words, because I have some problems. Yeah.
Sure. I was asking if you have any quick advice for the students that are in first, second year, or first starting and have interest in emergency medicine.
It's difficult to, yeah, it's difficult. Peter, help me. What would you like give students?
The advice is keep your options open, see what interests you. If you're unsure if emergency medicine is right for you, think about the situations where your friends came to you for different medical advice, where you were as a student had to be a doctor in that situation, right? And it's usually like the different falls, the sprained ankles, fractures, this, that, and it's like, what do you do? And if you can have that self-control, that stability in the moment, and you feel proud of yourself that you can help, and that carries throughout different aspects of life and different situations, then yes, I think that's a reinforcer of emergency medicine being for you. If you see yourself doing other things or helping, succeeding in different kind of tasks of medicine, then look at the different options. I would also suggest there's a really nice thing on Google, through studentdoctor.net, I think is the website, where it says choose your specialty, and it's like a little quiz of series of questions. There's about 100 questions, but it takes about like 7 to 10 minutes to do, and it helps you and it gives you different kind of percentages and scoring. And each question there's a scale from 1 to 10, and you basically choose, and then once you submit it basically breaks down the specialties which fit your lifestyle, your habits, your wants, your needs, and that's also very effective. So take a look into that. That'll give you also a gauge and open your eyes, and then also open your eyes into other topics and other specialties which you possibly weren't unaware of at the moment. I know you're first of 6, so you still have a long way to go, but be open-minded be open-minded and be always ready to help is the 2 things that I would say.
I will only add, listen yourself and follow your passion. But open your eyes is good, yeah? To actually, maybe I will like add check yourself, how you feel with something. That is good.
Where did you say that, Peter, sorry to interrupt, where did you say that that link was? Student Doctor Network? Was that where you said it was?
I will share the link here on the chat.
Okay, awesome. Thank you.
Good.
Thank you very much. Thank you for your answer.
No problem. My pleasure.
So I actually have one more question for you, if we have the time. So I know you covered a lot of information in this first session, but if there was one skill that you could have going into residency that you could advise us to work on as medical students, whether that's either suturing or intubating or learning how to take history, if you could pick just one thing, what would it be for us to work on going into emergency medicine?
Assessment.
Assessment. Okay. It's a good one. Okay. Thank
Assessment. Recognizing problems, how to find it. Yeah. Assessment is like the big spectrum, but assessment.
Got you. Okay. Thank you.
And the best way to prepare for that with assessment, that would just be working at the hospital and getting like your clinical hours correct, and just being with the patients.
Yeah. Okay, guys. Any information at the end? Actually, I want to say thank you, Nikita, because she kept me all time, and she was like my god angel. And I want to say thank you, because like my life right now is really difficult and hard, and actually like I'm sleeping not so much, but it's good. I have still smile, and I'm always optimistic, and I want to say really thank you and big hug, Nikita, for you.
No, thank you so much, Doctor, for taking out time from your busy schedule and being with us this evening. I'm very thankful to you.
Thank you.
Yes.
Okay, guys. God bless you. Thank you for the meeting. I hope we will meet again. And Nikita will discuss about the another levels of or areas of the project. Okay. Maybe we will find some kind of like a couple proposals. What we can do together. Okay.
Definitely. Yeah.
Thank you, guys.
Dziękuję, professor.
Thank you so much.
Thank you, doctor.
Thank you. Have a wonderful
Thank you,
evening.
doctor.
Thank you so much.
Bye.
Thank you, everyone, for having us this evening. Thank you so much.
Thank you, guys.
Thank you to everyone who
Good.
joined today.
Thank you.
Yes. Students.